Okay, well, I'm going to go ahead and start with a little bit of soft launch introductions on our end. So today we're excited that we are bringing back a topic that we've been touching on in the past and bringing you more information because they've done more with gathering information and basically developing what this curriculum could look like to support nurses on ACT teams. So our special topic today will be ACT Nurse Onboard Training Curriculum. And we have Heidi Herinckx back with us and Juli Templeton. So after I do some brief orientation, we're going to dive right in and they'll do their own openings and introduce themselves. And we're going to sit back and hear from them. Then we'll reserve some time at the end for some open mic where we just leave the floor to you all. It can be topics related to medical team and nursing, but we can also touch anything of relevance. We also will be sending out an evaluation that we hope that you take time to give some feedback and ideas, and also a heads up that technically in August 5th, is our last meeting that will be sponsored by the Northwest Mental Health Technology Transfer Center. So if you had not heard, it's very sad to us. SAMHSA can't stick to something too long. And they decided that they're going to once again regroup around how they're going to be offering different types of TA supports. And they're effectively disbanding of the Mental Health Technology Transfer Center network and redesigning something else that we're waiting to see what that is. But with that said, Maria and I started this without necessarily thinking about the Mental Health Technology Transfer Center funding it. They just patched in because it aligned with their scope of work and what we were all trying to achieve. So we're motivated to figure something out and continue to offer something to you all. We just have to sort out what that looks like and what support we can find. So just stay tuned. August will be our last one with this platform with the MHTTC. And a little bit of housekeeping. You're muted. There will be an opportunity for you to raise your hand and then potentially come off mute to talk. Your video's off because there's 150 of you, and that can be dizzying and you'd use a lot of bandwidth. This is being recorded. As you may have seen, one thing that is really cool from this is that there's a library out there of 5 years of content of us coming together, touching on a lot of different topics. So if you're ever curious about where can I find this, put that out there and we can drop that in the chat for you to know where that library exists. Also, the slides get posted too. So the information that gets shared here, there's a library out there that's being kept. And again, once the MHTTC phases out, we're going to find ways to preserve these resources so you can continue to access them. Use the chat when you just want to put out there information to us without an expectation for response. Peyton will be monitoring to make sure if technical issues come up, that we can respond to those. And also if you put something into the chat that really deserves a response because it's a question, we'll be asking you to put that over in the question box. So we'll be trying to make sure information is showing up where it should exist. Some questions we'll try to respond directly by writing, but if it's something that really was deserving of hearing back from Juli and Heidi, we'll say we're going to pose this to them and answer in front of everybody. And I mentioned open mic. The raising your hand is the way to signal to us that you're hoping to be heard out loud. And you may notice that I'm missing my other better half, the nicer half, we joke. Maria is deep down the sweetest person, so it's hard to be sweeter than Maria. But I'm Lorna Moser, and I'm the co-author of the TMACT and the Fidelity Tool for Measurement of ACT. I'm the director of UNC's Institute for Best Practices, which is a technical assistance center that I have a team of consultants and trainers that do work with ACT, IPS support employment, housing first teams in North Carolina and other places. I'm a licensed psychologist, do a lot with mental health services research. You probably have heard, which we're going to talk about in August will be our topic, is we're wrapping up this large descriptive study of ACT. So in August, that will be our topic, is to bring more of that data back to you because the study is finally wrapping up. If Maria was here, she would say ditto. She's doing all those things, but from the perspective of University of Washington and her technical assistant center there with Spirit Lab. So she wasn't able to make it. Family emergency is taking her away. And so you have me and then the support of everybody else here. So with that said, let's give this over to Heidi and Juli.
Thanks, Lorna. All right, I'm going to switch over to show our PowerPoint. All right, can everybody see that okay? Okay, fantastic. All right, I just want to move this over a little bit so I can see my screen. Oh, and advance my slides. So I think I'll move it right there. All right, now that we're getting all situated, I really want to thank Lorna and Maria for inviting us back to give an update on this very exciting project that we embarked on. It's been a number of years, like too many to count to really think about kind of when this project got started. So just a little bit about myself and my background before we move on to talking about our project. Again, my name is Heidi Herinckx. I am the Senior Director of 2 Centers of Excellence that are in operation in Oregon. The first is the Oregon Center of Excellence for Assertive Community Treatment. And the second is the Oregon Supported Employment Center of Excellence, both centers operating out of Options for Southern Oregon. I joined Options in 2013, and that was our state's first time that we were actually implementing the ACT model statewide. And I joined Options with that mission to really implement ACT statewide. I had worked for the Regional Research Institute at Portland State University for 18 years prior to joining Options. And I first got my first exposure to ACT going back into 1994. So I guess I'm celebrating 30 years working with the ACT model, which it's hard to believe it's gone by so fast. But my first exposure to ACT was as a project manager for a randomized clinical trial of ACT that was going on in Oregon at that time. And then I spent the better part of my career at the Regional Research Institute, writing grants to implement assertive community treatment in various community mental health agencies in Oregon and even in Southern Washington. I worked a lot with Clark County, Washington, back in my Regional Research Institute days. But the last 6 years working with the Regional Research Institute, I worked really closely with the Oregon Health Sciences University School of Nursing. And they had embarked on this project called the Oregon Consortium for Nursing Education. And nurse educators from the Oregon Health Sciences University and 10 community colleges, and I think ultimately they ended up with 12 community colleges across Oregon, redesigned the pre-licensure nursing education for RNs, and we're implementing it across the state of Oregon. So all 10 community colleges at that time, all 5 campuses of the Oregon Health Sciences University implemented this single curriculum across all of their campuses. And I co-wrote a Robert Wood Johnson grant with the Dean of the School of Nursing at that time to do the evaluation for that implementation project. And through that, I developed a fidelity scale for their implementation of their curriculum and really met some amazing nurse educators, learned a ton about evidence-based practices in nursing education and nursing pedagogy. And I think that's actually probably what gave me some sensitivity to what are the needs of nurses, right? And what are the needs particularly of ACT nurses as we were rolling out our Center of Excellence and recognizing that we needed some specialized curriculum and training for ACT nurses specifically. So I'm also very happy to introduce Juli Templeton. Julie's been with us for 7 months. She started with our Center of Excellence in October of 2023. She comes to us from Columbia Community Mental Health, where she was an ACT nurse for 4 years. And she has 9 years of experience overall. She's an RN, but she's currently working on her master's in nursing education. So that'll come in handy in this role. She is also a certified tobacco specialist, and her real passion is health education and health promotion. So you'll really get an opportunity to see her light up today as she's presenting part of the module that we're developing around health education and health promotion. So we're super pleased to have Juli join us. So today, as Lorna mentioned, we presented to this group, and I guess it was back in October 2022. Can you believe it, Lorna? It was like 20 months ago. Feels like yesterday. But we presented in October of 2022, and at that time we were working with Paula Gubrud, who is a nurse educator that I had worked with at through the OCEACT project, and I had brought her in to help me kind of conceptualize the initial project plan for developing this onboard curriculum. And so she was the one that suggested that we conduct a DACUM. And so the DACUM stands for Developing a Curriculum. And it is a process in which you create an expert panel. And so we had an expert panel of 8 nurses from Oregon, Washington, and New York. And we spent 5 days where we really did a deep dive into the role of the ACT nurse. So since the time that we conducted that DACUM, in the 20 months since that time, we'll kind of give you a little update of what we've been up to. Then we will also, as part of that, the second piece is that we'll summarize the DACUM. So if you weren't present in that last October 2022 meeting, or even if you were and it's been 20 months and you've forgotten what we talked about, we'll give you a little bit of an overview and how we're now using the DACUM to design our 8-module nurse onboard curriculum. And then finally, we'll discuss one possibility for a training process, right? There's many ways that we could potentially utilize this nursing curriculum to create an onboarding process. And we'll talk about at least one idea that we have for putting this into practice. So over the past 20 months, we have been very, very busy. We have had an opportunity to validate the DACUM findings. And we've published a paper on those findings in Issues in Mental Health Nursing, and that came out actually in April. So if you would like to see a more in-depth conversation about the validation of the DACUM, that article is published there. We have secured funding from the Oregon Health Authority and for a full-time ACT nurse trainer, which is Juli. So the funding came through in July 1 of 2023. And since we were able to hire Juli in October, and we've been working with Juli for 7 months. And since that, in those 7 months, we've been able to create 3 out of our 8 onboard modules. So that's basically the work that we've done so far. And we're working diligently on getting the rest of those modules created. So just a little note about who we are and what we do. So OCEACT, as I mentioned, is a training and technical assistance center. We were created in 2013. We support 33 ACT programs throughout the state of Oregon. We have a dual role in that we are both a training and technical assistance center, but we also perform annual ACT fidelity reviews. So in Oregon, each ACT program needs to go through a certification process. And OCEACT is the organization that conducts those fidelity reviews in order to inform OHA on meeting OHA and OAR requirements for certification. And it was really through those fidelity reviews that we started to recognize the need for this project. So from fidelity reviews, we interview all members of the ACT team, including the ACT nurses. And we started to hear from nurses that they really needed some training and technical assistance that we didn't have the capacity to provide or the materials to really provide. So it was around 2019 when I started to kind of recognize that we have this big gap, this big unmet need for ACT nurses. And my first thought was, why recreate the wheel if there's already something out there that other people are using? Let's just, see if we can adopt that and maybe modify it for our state. So I did reach out to Lorna, and I reached out to Maria, and I reached out to Hella Torning and Luis Lopez from Columbia University, the ACT Institute there, through their Center of Practice Improvement. And there, to our knowledge, was not a national recognized curriculum for ACT. So that left us with, okay, well, what else can we do? How can we best start developing a training curriculum and meet the needs of ACT nurses? From the information that we were receiving from the ACT fidelity reviews, nurses were really reporting that they needed more specialized expertise in various components. So even if an ACT nurse or a newly hired nurse had 17 years of experience in the field, but they'd only really provided nursing services in an inpatient setting, providing services in community-based settings felt very uncomfortable. Other nurses were coming into this work saying that they hadn't had a background in providing nursing specifically to people with serious and persistent mental illness, right? Working with people with diagnoses that includes psychotic disorders. And they felt more like they needed some more specific training on therapeutic communication or psychotropic medications or monitoring medication side effects particular to these specific psychiatric disorders. So, once again, as a training and technical assistance center, we were feeling like, how can we best meet this need? And at the time, we didn't have anything really to offer. Third, nurses were reporting that they had insufficient orientation and onboarding from their organizations. Many ACT programs that operate in Oregon might have only one nurse. Oregon is a state that's largely consists of frontier and rural communities, right, with really low population density. In fact, 60% of our ACT programs operate in rural and frontier communities where there is only one ACT nurse. And so if that nurse leaves and it takes a long time to hire a new nurse, then the nurses were reporting that they were left to piece together the essential duties of their job on their own. And maybe the person that trained them had no nursing experience before. So once again, that's really a gap that we felt as a training and technical assistance center. We could help actually fill that need, right? Finally, the biggest driver for this is really high staff turnover. Among the ACT programs in Oregon, from 2018 to 2021, ACT programs were experiencing a 55% annual turnover rate. So again, that could speak to is the dissatisfaction that nurses might have, the feeling like they aren't feeling comfortable in their role. And, with the national nursing shortage and the overall shortage of behavioral health providers, we felt if we could actually hire an ACT nurse to begin with, we need to do everything we possibly can to hold on to them. And so that's really our ultimate goals. How can we provide training and technical assistance to nurses to help give them the competencies that they need to really feel good about their work and continue to stay in this work for 30 years like me? Because we really want people to have some longevity in this work. It takes a lot of resources to train and retrain people, right? So if we want to reduce administrative burden and reduce and increase sustainability of staff, we really need to do all we can do to help people feel mastery in their role. So our first step was to conduct the DACM. The DACM stands for Developing a Curriculum, and it's an occupational analysis that's performed by a panel of experts. We had 8 nurse experts, 6 from Oregon, 1 from Washington State, and 1 from New York State that was on our original panel of experts. We all spent 5 days together fleshing out the duties and roles that ACT nurses perform in their day-to-day work, and arrived at 9 duties and 127 tasks within those 9 duties. The DACM also was able to identify the knowledge and skills and behaviors that ACT nurses perform in their role. On our website, if you're interested, we have a lot of resources available for each role on the ACT team, but ACT nurses in particular. And on our website is this particular DACM chart, which provides the results of the DACM. And both myself and Paula Gubru became DACM facilitators. We took a class through the Ohio State University, the International DACM Institute, to learn how to conduct a DACM. But our team leaders got so excited about this project that they said, can we do it as part of sort of the culmination of the course? And we're like, that sounds fantastic. So we organized our panel, and then we had a whole cadre of facilitators who helped conduct the DACM. But this tells you who were on that original DACM panel. And the DACM chart itself identifies each of the duties that ACT nurses perform. And then within each of those duties, and again, there are 9 of them, this first page represents the first 4. And then all of the tasks, I should say, that are within each of those duties. So if you look at the first duty, for example, managing ACT participant medications, there are 15 associated tasks within that duty. So because a panel of 8 nurses isn't a representative sample, right, of ACT nurses, a really important second step is to validate the findings of the DACM. And so this is where I reached out once again to Lorna and to Maria, who helped me disseminate a survey to ACT nurses in Washington, North Carolina, Virginia, and for the nurses in Oregon that had not participated in the DACM, we asked them also to participate in the validation survey. We reached out to approximately 250 nurses in each of those 4 states. We had a response from 57 nurses who completed the survey for a response rate of about 34%. The median years of experience for ACT nurses was 17 years overall, with one nurse having as many as 41 years of work experience. The median years of experience as an ACT nurse was 3.5, and that the range there was 1 year to 11 years of experience. And so what was pretty clear from these data, as well as some of the other data that we collected as part of the validation sample, is that nurses were coming into their role as an ACT nurse later in their career and didn't have as many opportunities pre-licensure to be exposed to ACT nursing. That was that's an interesting thing that's kind of been also rolling around in my mind about how can we provide opportunities for nurses to really learn about ACT nursing earlier in their career. I think one of my colleagues, Alyssa Curlinger, if you are on, if you can provide a link to this publication in the chat, that would be fantastic. I think we have 200 free copies available through the publisher. So if you're one of the first 200, you could get a free copy that way. Also, of course, if you subscribe, if your organization subscribes to Issues in Mental Health Nursing, you can access the publication that way. Or if you're affiliated with the university and can go through interlibrary loan, that's also an option.
Alyssa dropped it at 3:15 for you all if you go up in the chat. And Alyssa has been dropping links to other resources off your OCEACT page, so you know.
Fantastic. So another important question that we asked and that we were able to get from the validation survey was, this is a lot of information, a lot of tasks that nurses perform. With 9 duties and 127 tasks, we felt like we needed a way to prioritize the tasks that were reported in the DACM and how can we prioritize in the nursing curriculum. The first thing that we did was we tried to see if can we hone down these 127 tasks into tasks that are really specific to the role of the nurse, because we know that every team member on the ACT team performs kind of a generalist role and a specialist role, right? And some of the work that nurses were reporting that they were doing fell more into the generalist role. And you didn't need specific nursing experience in order to do that work. So when we looked at those 127 tasks overall, we felt there were 70 that really you needed a nursing degree and the credentials and the specialist expertise to really do those specific tasks. So that's what was included in the validation survey. And those were the tasks that we asked ACT nurses to rate. And we asked them to rate those tasks on 3 dimensions. The first was, how important is that task to your work? The second was, how frequently do you perform that task? And the third is, how difficult is this task to learn for a brand new nurse? And as you can see, each of these dimensions are scored from 1 to 5, where 5 is the most important, the most frequent, and the most difficult to perform. And then we basically created a composite score where we summed those ratings across those 3 dimensions. So the composite score is a score of 3 to a score of 15. So when we were able to sum that composite score across the 57 nurses, that would give us a total score for each task. And that task and the total score were the ones that ACT nurses collectively rated as the most important, the most frequently performed, and the most difficult. And when we rank those tasks, then that gave us the prioritizing that we needed to really determine which tasks were most important for the nursing curriculum. Does that make sense? Okay. So, for example, this chart provides the top 5 ranked tasks that nurses felt were most important, most frequently performed, and most difficult to learn. In our paper, we provide a table that has the top 10, but for this presentation and for space, I'm just going to provide the top 5. But, and this is probably, I mean, we could probably sit and stare at this chart and interpret the findings for the whole next hour, right? And probably we're going to be spending a lot of time interpreting these findings, but just even this first task, right? Monitoring changes in ACT participants' behavior. ACT nurses say that they do this often. They do it frequently. It's very important, and it can be difficult to learn. And when you think about even just doing this one task, you can start to see why, right? There's a lot of competencies that go into just this one task. A nurse has to know the signs and symptoms of serious mental illness. And for schizophrenia, for example, that would mean knowing both positive symptoms of schizophrenia, negative symptoms of schizophrenia, as well as how cognitive challenges of schizophrenia present themselves. There's also bipolar disorder and other psychotic illnesses that ACT nurses really need to have a lot of knowledge about. And then in addition to that general knowledge, you also have to have really specific knowledge of each individual participant, right? You have to know what the prodromal symptoms look like for each person. And each person has their own idiosyncratic way in which mental illness presents itself for that person. So you also have to have really good therapeutic communication skills and really have developed a good relationship with each person that you're serving. And then finally, it also requires clinical judgment. And nurses will have to know at what point is a change in an ACT participant's behavior, at what point does it rise to the level that an intervention or a preventive strategy might be warranted. And that might also involve communicating with other members of the ACT team and getting other professionals' perspectives on what their interpretation of a change in behavior might indicate. So when you start to really unpack each of these tasks, you really start to recognize all of the competencies that are needed and could be covered in a nurse and an onboarding curriculum. So overall, the DACM indicated that the nurses in the validation sample, they confirmed that they also conducted 80% of the tasks that were identified by the expert panel. So we felt like that was an excellent sort of validation that the original expert panel had identified the tasks and duties that other ACT nurses also confirmed that they also perform. And in fact, the ACT nurses in the validation sample performed all of the tasks in the first 2 duties. So for managing participant medications and performing nursing assessments, those first 2 duties, that represented 27 nursing specific tasks And all of the nurses in the validation sample said that they perform all of those tasks. So with those findings, we really felt confident that we could proceed with using the DACUM as the framework or the roadmap for developing our competency-based curriculum. So we have 8 modules that we're developing based on the DACUM. The first module, Module A, again, is medication management, and it focuses on setting up a medication room, managing the MAR, management, distribution, and cross-training, administration, lab requirements, safety, a primer on mental health diagnosis, which includes presentation for individuals that have diagnosis typical to those that are served on the ACT program. Module B is performing assessments, and this would be the nursing assessment, a sample of a comprehensive nursing assessment, medication side effects, common health screenings. And in our training, we've focused on things like the PHQ-9, the slums, suicide screening and assessment, and tobacco screening. There's a triaging immediate health concerns training, active listening and shared decision-making, safety assessment, and complex care coordination. For Module C, that's about coordinating care with the ACT team, and particularly working with the ACT prescriber. The cross-training that's necessary for medication delivery and side effect monitoring, supporting ACT participant goals, ACT team meetings and treatment planning, and particularly the role that the ACT nurse plays in helping people remember when shots are due and medication administration and delivery and things like that. The generalist versus the specialist role. And then Module D is ACT nursing interventions, which includes frequency and intensity of specific nursing contacts, nursing orders, scope of practice, therapeutic communication and symptoms, crisis intervention, harm reduction, and recovery-oriented care. For Module E, health education and health promotion, Julie will be giving a little snapshot of that module in a few minutes, but it focuses on common health conditions and social determinants of health for people living with serious mental illness, a health education and promotion framework, common topics for health promotion, and we've felt like that each one of these could probably be its own class. But in our training, that's, I think, one of the biggest challenges so far has been, you know, where to stop and how long should these trainings be? But we provide kind of an overview at this point of the common topics for ACT nurses, teaching strategies, and tips and resources for running a group. Module F includes supporting ACT participants in the community. And again, these are things that all ACT staff might participate in, but there are special considerations sometimes for ACT nurses, particularly when you're visiting ACT participants like in jail, that's often related to medication delivery and coordination. Accompanying participants to wellness activities and doctor's appointments, modeling and coaching pro-social behavior, community-based needs, and advocacy. Module G is performing case management. And once again, in nursing, there's a whole sort of specialty area within nursing around case management. And so it's coordinating with healthcare specialists, identifying gaps in care, accompanying ACT participants to medical appointments, obtaining healthcare benefits, appointment reminders, helping with insurance, accessing auxiliary care like home health care or personal care assistance. Module H has to do with supervision and support and professional development for the role of the ACT nurse. And we've been spending some time thinking about the supervision needs for ACT nurses. Nursing licensure and certification, practicing at the top of scope of practice, making sure that there's clear policies, procedures, and guidelines and lines of communication, stakeholder training, ACT fidelity requirements, tracking systems, medication supplies and inventory, and quality assurance. So, again, our goal for developing the DACOM and developing this nursing curriculum is all about training. It's important that the training that we develop is aligned with fidelity requirements, and our training, our DACOM findings indicate that they are consistent with these 6 core elements in the TMACT. And fidelity tools don't give you everything you need to know to do everything about your role, right? So while we identified 127 tasks that ACT nurses perform, we're not saying we want to see 127 essential criteria on the TMAC. That is not what we're saying at all, right? It is all about how can we develop the competencies that ACT nurses need to do their role and still feel happy and content that this one measure is a nice snapshot of the core functions that ACT nurses do. So we're not trying to up the ante on fidelity requirements. We are trying to support nurses in what they say they already do. That's the other part of this. The DACOM wasn't OCEACT coming up with a bunch of new things that ACT nurses need to be doing. These were all things that ACT nurses themselves said that they do in their everyday work. How can we support them? How can we make sure that they have the training to feel confident that they're doing these things competently? So I do really just want to give a shout out and thank the Oregon Health Authority, both for their support in the early development of this project, in developing the DACOM and giving us the funding to do the study, to really make sure that we're on track with the nursing curriculum. And then most recently, and that was all with our evidence-based practice coordinator, Brenda Dennis, who supported that initial work. And we're currently working with our evidence-based practice coordinator, Angela James, who really went to bat for us and advocated to get a full-time ACT nurse trainer added to our team. So without that support from the Oregon Health Authority, we wouldn't be able to really do this really great work. So we very much valued the partnership, and we're hoping that we can really meet the needs of ACT nurses across Oregon, and then also make our training materials available to other training and technical assistance centers so other nurses and other programs can benefit from this work as well. So in addition to the developing of the training materials, which is the primary role that Julie's helping us out with, is really helping us flesh out the training materials for new ACT nurses. I'm really excited to ultimately get down to these last two bullet items, which is developing relationships with nurse education programs, so that we could potentially create a better pipeline for new ACT nurses, so that they're aware of this fantastic work that we do on ACT programs, and that maybe we can develop some integrated practicums where new nursing students can really be getting their feet wet with working with ACT nurses in community-based settings, and eventually maybe get hired onto working with ACT programs. And then also, again, professional development and workforce retention. We really do need to improve our retention rate for ACT nurses, particularly in Oregon. We've been hearing that other training and technical assistance centers around the country are able to hire nurses as well. Maria reported that they're going to be able to add a nurse trainer to their training and technical assistance center. And through Maria, we've been introduced to Idaho's newest Center of Excellence, and they have 2 nurse trainers on their team, as well as a psychiatric nurse practitioner. So we've been working with Billy and Laura and Sandra and providing some input as to kind of how we're going about developing our training for ACT nurses. So with that, I will turn it over to Julie, who will give a little bit of an introduction to one of our modules that is from the Health Education and Health Promotion Module E. And again, all of these materials we will be putting up on our website, and be making these available to any other training and technical assistance center that would like to take advantage of using these materials. So go ahead, Julie, if you'd like to take it away.
Thank you, Heidi, and hello, everyone. I am really happy to be here today and working with this amazing team. Getting to participate in this essential project has just been absolutely wonderful. And like Heidi mentioned, I got to work on an ACT team for 4 years before coming here. And while I was there, I worked for a fantastic medical director that was notorious for saying, "Don't come to me with a problem unless you have a solution." So with each challenge and dilemma I encountered as an ACT nurse, it got me looking for solutions and asking, how can I make this better? And in my role on OCEACT now, I get to do that. So as we all know, in today's dynamic and complex modern healthcare system, the knowledge demanded from nurses is extensive. However, the time constraints of nursing education make it impractical for nurses to acquire all of the necessary skills for a specific specialty, such as the ACT nurse's role. And this is where our training modules step in, providing essential guidance and knowledge to enhance the skills and capabilities for ACT nurses. All of the module trainings follow similar designs as the one you see up right now. And we are going to look at just a few slides from Module E, covering health education and health promotion, which is one of my favorite parts of being a nurse. Can we have the next slide, please, Heidi? So the learning objectives in this module identify the need for health promotion and education for ACT participants. The framework to promote person-centered care, which is really the foundation or the starting in providing health promotion, includes understanding the learning process and teaching techniques nurses can utilize for individuals and groups. Person-centered care is a holistic approach that focuses on the individual's unique needs, preferences, and values, and it is crucial in health promotion as it ensures that the interventions are tailored to the individual's specific circumstances You'll see this emphasized throughout all of the trainings. Common topics and ideas ACT nurses will teach for health promotion is covered. And health promotion is, I want to say it's in addition to patient education concerning medication and disease processes. As ACT nurses, we will definitely still need to do that for the things that patients and participants need to know. But health promotion is a little bit more. There is a deep dive into cardiovascular disease and what individual health promotion might look like for that. A case study on metabolic syndrome and how to support participants with person-centered health promotion is also reviewed. And lastly, tips and resources for teaching, managing a group, creating a trusting and caring environment, and addressing incivility and group behavior standards. Next slide, please, Heidi. So the framework we are going to use to build health promotion for ACT individuals and groups is based on the new directions for building a better health service guide for person-centered goal setting. Successful health promotion is person-centered and determines what outcomes and participants' wants and needs. The first step is to discover what the participants' dreams and wishes are. These wishes may not be directly health related, but often require improved health or stamina. And by uncovering a participant's deepest motivations and desires, a health treatment plan that is motivating, participants will likely want to stick to, and creates an environment of collaboration between the nurse and the participant. Step 2 is turning wishes and dreams into goals. Step 3 is making those goals SMART. SMART goals is a plan with actionable steps that are obtainable, accomplishable, and likely to increase the completion of the goal. Without action steps, the dreams are likely to remain dreams. In step 4, differentiated learning strategies are used to support and encourage the participants by providing tools and learning how to achieve their goals. And in step 5, it addresses supporting autonomy in participants to improve their wellness and foster independence in the community. Next slide, please, Heidi. So many of the nursing governing bodies hold expectations for nurses to impactfully teach health promotion to participants, family members, and the community as a whole. Many nurses find the idea of teaching overwhelming without knowing how to start. Finding time to put together group activities and health promotion can also be challenging for ACT nurses. The ANA and the Nurse Practice Act identify teaching as an essential nursing component. It states that nurses are required to teach health promotion and education, but they are not taught how to teach. So health promotion needs to be implemented to meet the goals of improving participant health and their quality of life. And this module and curriculum are designed to fill in knowledge gaps and support nurses in feeling confident in their teaching role. Next slide. ACT nurses provide education on a wide variety of health topics. Health topics and health promotion are always tailored to meet ACT participants' needs. And because, like Heidi mentioned, each of these topics could very easily be a training all of its own, we do a deep dive into only the 2 top topics and provide an overview of the others, keeping the framework in mind as a tool to build person-centered care. Next slide, please. The introduction of teaching strategies and tools, such as the mind map shown here, are used in case scenarios to provide health promotion. It provides a graphic illustration of how the ACT nurse might work with individuals and create a map of strategies to help them manage things like high cholesterol, blood pressure, and elevated blood sugar levels. Each helpful health strategy is written on the map to help a person visualize how each strategy works together to create holistic health for the participant. In this training module, we also provide comprehensive tips and resources for teaching managing groups, creating a trusting and caring environment, and addressing instability and group behavior standards. This report is designed to empower the ACT nurse in their role. So I know this is a really brief snippet, but we just wanted to give you guys an idea of what the other trainings entail. And with that, I will turn it back over to Heidi.
Thanks. Okay, well, thank you, Julie. And as I mentioned, we are in the process of finishing all of our 8 modules. We've got really 3 of them finished at this point, and we've got a really good start on almost all of the others as well. But with our goal, our intended goal is to finish all 8 modules by the end of 2024. And then second, we will be piloting our onboarding process. And finally, we'll be measuring annual ACT nurse retention rates with the hope that providing a more systematic onboarding process and supporting ACT nurses in their role will increase their job satisfaction, competency, and then in turn produce an improved retention rate. So one possible process that could be adopted for onboarding for ACT nurses is kind of an individualized approach where we identify gaps in knowledge or skills that each individual ACT nurse has, and then create an individualized training plan to meet those goals. So we have developed an ACT nurse competency self-assessment. And our hope is that we will be able to offer the self-assessment to newly hired nurses. And if they choose to participate, if they'd like to fill this out and be able to utilize that as a way in which we can determine which areas that an ACT nurse needs some additional support and coaching, then Julie would be able to then develop an individualized training plan based on that individual nurse's specific needs. From there, then Julie could provide some training, either one-on-one or offer, let the nurse know when there's going to be additional trainings that are going to be provided, and scheduled, that are already scheduled to be provided in a group setting. That training could also look like some guided apprenticeship, some mentoring and coaching. And then we hope to then track each of the trainings that the ACT nurse completes. Hopefully track their improved competency level. And then again, hopefully that will improve retention rates. And part of the reason why we're thinking that we'll start off with kind of a voluntary approach is that, again, ACT nurses will come into this work with a variety of backgrounds, right? So if a community mental health agency is lucky enough to be able to hire an advanced practice nurse with, 20 years of experience providing psychiatric care, they're not likely to they might say, I got this, like I'm just, we're not going to stand in folks' way and say, no, you have to, go through all 8 of our modules before you can be an ACT nurse. But we do want to really ensure that for nurses that don't have the knowledge or background in ACT nursing and don't feel comfortable in community-based settings or really have a deficit in their knowledge of working with individuals with diagnoses of serious and persistent mental illness, we want to be able to provide that training so that people can really feel comfortable and confident in their role. So in conclusion, we are advancing in our goal of creating onboard curriculum for ACT nurses We do hope to be able to make this available to anyone and everyone who would like to utilize it. We understand that every state has their own administrative rules and their own Nurse Practicing Act. And so, there may be some adaptations to these materials that you would need to make in order for them to be applicable in your own state. But if you do, take these materials and run with them, we would love to hear from you. Because, as Lorna was mentioning, I think one of the big values of having us all come together and be this, learning collaborative is that we can all learn from each other. Certainly, we benefited greatly during COVID, right? When we were all really struggling for understanding how are we going to maintain ACT services during this really challenging time. So I've benefited greatly from all of the work that you've done, Lorna and Maria, and I'm really sad to see that the mental health technology transfer centers are not going to be funded because they've just served such an amazing role for all of us who've really worked in this field for such a long time. So I really appreciate all the work that you've put forward for this.
Labor of love for us all, isn't it?
Yeah.
Well, thank you both. We have a couple of lingering questions. I could see, Heidi, you were trying to also keep up and answer things as you saw them coming in too. One that came both from two sources, and I think you just addressed it, is questions around like, so is this going to be accessible to people other than just ACT nurses? So if team leaders want to go through this to understand what's being taught to the nurses, somebody else mentioned, of course, the ACT supervisor, that sometimes agencies have somebody outside of the team, supervisor of nurses. It sounds like you're intending for this to be accessible to whoever finds it helpful to go through.
Absolutely. Yeah. And I think that that's one of the things that ACT nurses really said is that not everybody understands their role. There's a lot of people within our own organization that don't understand at all what we do. And so that's prompted me to be thinking about how can we hold maybe trainings that are broader than the ACT team, right? How can we kind of maybe go to every community mental health agency and just say like, let's meet with the entire medical team, or let's meet with a broader array of stakeholders so that we can provide a training on what are all the things that ACT nurses do, because it's a tremendous amount of work.
Another person had, before I ask this one, I was going to ask, I love the idea of doing that kind of needs assessment and the idea of Juli maybe coming back with a more tailored plan for a given nurse. That's the layer where I think as you all try that out, other states that want to try to replicate something like that, I think that's a down the road of kind of learning how that works and how could they integrate that process within their own state.
Yeah.
Okay. So Doug had asked, and this is a great question. I think Juli, you shared earlier, this is cuts the heart of a lot of work you like to do around the overall integrated health piece. And so Doug had raised, and we have healthy disputes on this sometimes within our group. When it comes to smoking cessation, which is a huge need for our population, I think it's like 60 to 70% of people with serious mental illness typically are tobacco users, compared to now the general population being probably around what, 17%, 16%, I think is last I saw. So huge, discrepancy there. Do you see that smoking cessation interventions benefit from nursing working in conjunction with substance abuse specialists? Sometimes there's discussions around whose camp does this really fall under?
I definitely think it falls into the nursing role. Especially as an ACT nurse, we have a lot more one-on-one time with the participants and can see them, on a regular basis to help out. And oftentimes they need multiple streams and interventions to quit smoking. And reminders that every quit attempt, every small step, whether it's just reducing your entire smoking allotment by 1 cigarette within the week, is a step towards quitting, and to keep encouraging them. And then, of course, we also can help them get access to NRTs, the nicotine replacement therapies, and scheduling them with their counselors is a big part of helping them quit. This is my other favorite part of the health promotion. I definitely think that all smokers, all tobacco users in general can benefit from it, but ACT participants in general benefit when their nurse is really strong in that area. And I can actually give a really perfect example of why. When I first started as an ACT nurse, there was a participant that started on NRTs, and there was concerns that they would overdose on the nicotine, make themselves sick, things like that. And as I learned about the Tobacco Cessation and got into the role, I realized it's very unlikely, and the statistics of it and how the NRTs work. And that kind of knowledge really helps support the ACT participants. Does that answer the question?
It does, yeah.
I think one point I'd like to add there too is that tobacco use can really impact how medications, other psychiatric medications, are impacting a person. So if the nurse or the prescriber isn't aware that somebody is reducing their tobacco intake or their nicotine intake, that can have consequences for how others psychiatric medications are working. So it's important for both the nurse and the prescriber to be aware of individuals who are drastically reducing their nicotine intake.
Thank you for reminding me of that, Heidi. It also helps with all substance use and helping reduce addiction rates when you can help lower tobacco use. That was perfect.
So Katie had asked about just, have you thought about how you would make all of this accessible? Is it something that you're envisioning free recorded modules? Is it something like people would pay for?
So my feeling is that this is public domain, right? And we're going to be disseminating information on our website about both our slide decks and our manuals that can be accessible on our website eventually. And then I think with periodic updates, so as we're refining the materials or as we are updating things and making sure they're all clinically relevant and with new information, we'll probably have like periodic updates where once a year we go in and we replace materials or those kinds of things. So the best place, of course, you can reach out to us anytime. And I was going to end with this last slide, and I'll just put it up there now. This is our contact information for all of the members of our center. And you can reach out to us at any time. And again, www.oceact.org, there's a nursing resources page where all of these materials will be provided in terms of the curriculum. And there's lots of other resources available there now as well.
Perfect. Well, thank you both very much. And we had nearly 200 people here.
Yay. Well, I hope that this work gets put to use, and I'd be really happy to hear any state that's going to be. I think Idaho is agreeing to help us out in piloting this information. But again, how we're ultimately going to chunk this out and provide it's probably going to morph over time. Each module in and of itself right now is probably going to be about 3 hours, right? 3 hours of training material. So if a nurse were wanting to receive all 8 modules, that's 24 hours worth of onboard training. Again, we don't necessarily have any intention or any specific goals to require this 24 hours worth of onboard training before ACT nurses could hit the ground running. But we do want to create a library so that when nurses come to us and say, my nurse left, the nurse for our agency, our whole entire agency left 6 months ago. I don't know how to set up a room, medication room myself. Can you help me? And then we can say yes, and we know exactly how to do it. And Julie, who's, got the training and education and credentialing to be able to make sure that that's done right, can actually step in and help.
Well, we have a little bit of time to do some open mic. We have 19 minutes, which is probably twice as much as we often have. So that's great. So we can, again, we can host topics that's still relevant and specific to nursing, or you can go off the range and pick whatever topic or question you want, and we'll see if we can respond. And this is where you can put it in the question box, or you can raise your hand and be brave and come and talk to us live. Oh, and Doug's bringing up caffeine. It's all the stuff, Doug, all the stuff I love that's bad for us needs health interventions. Sedentary behavior, poor nutrition, excessive caffeine, nicotine, it's all the fun things. But they're oftentimes doing it proportionally, even at a higher rate, and creating more problems. So, right. I don't know if you all wanted to, Doug was just kind of like anything specific to caffeine you imagine being in the curriculum, and how that also interferes with medications too.
It is mentioned a few times. And another thing a lot of people don't think about is hydration. It really affects hydration. For each caffeinated beverage, if you drink one water, it cancels it out. And I am personally a huge fan of caffeine. So for me, that falls into harm reduction. Or moderation. Moderation is good. Yes.
Doubling up your water so you're not fully canceling it out. Yeah, I like that.
Yeah. I'm not aware of any specific training like there is for tobacco cessation, though, for caffeine.
Well, so much with caffeine and nicotine, it's trying to stimulate them in a way that's compensating for the challenges that often come with the medications they're taking, or the cognitive impairments that come as part of the symptoms that they're experiencing too. So it's trying to find other ways that are able to activate them a bit more. That's not a substance.
Right.
Yeah.
And caffeine affects sleep so much as well. And that's one thing a lot of ACT participants struggle with, is getting, adequate and quality sleep.
Yeah. All right. So what training do you have available for nurses to access now? So I'm not sure. That's another one of those state by state unique things that I think happens often. So did you have anything specific?
Well, we do have the 3 modules that are posted online right now. The other ones will be the plan is by the end of the year. And for the really in-depth stuff, we do TA calls either quarterly or monthly. And that's when we really get to deep dive with the nurses on those specific things. Not sure if that's.
Yeah, I think that's the one thing, I guess that's I'm glad you're bringing this up, Julie. So for our Training and Technical Assistance Center, we host monthly TA calls, and they range on a wide variety of topics. And sometimes we've actually even done them by specialty. So we'll have like a monthly TA call for the SUD specialist and one for the employment specialist and so on. And so one for the nurses is definitely something now that we have Juli that could be specific to the role of nurses. So that's an option. That's something that we can consider offering as part of our ongoing training series. We also host a statewide conference, which for us is coming up in 2 weeks. And so Juli will be presenting a session for ACT nurses on health promotion. So stay tuned. If you're an Oregon ACT nurse and you'd like to get that full module of training, then that will be presented at our OCEACT conference in June. I guess it'll be what, the 11th and 12th.
Yeah, so I think as you're sharing, we offer a lot of broad sweeping across roles trainings, but then once a year have a focused team position come together for several hours in a day to talk. So I think that's one of the things is, in the United States, because we are the United States, each state who's doing ACT, if they have invested in some TA resources, typically we're all doing things a little bit on our own. And I think that's one of the cool things of this effort is trying to create something with the intention that standardizes the curriculum so people can use it across all the states.
Yeah.
I would like to add for other states using it, definitely check the specific laws and things, because even here within Oregon, in different counties, it's different. So it's very individualized for each ACT team as well.
Right. Question that come up, I noticed in the chat, I don't know if it got moved over yet. And this comes up for us often is around, if you look at the old PACT manuals, they would talk about nursing as case managers. And I think sometimes programs have run with that to the point that the nurse is doing considerable amount of case management to the point that they don't have a lot of time left to do nursing work. And so I saw questions asking about, like, is there examples of job descriptions and tasks, just something to kind of even help with advocacy around how to structure this role. I'm a believer that all nurses are equipped to do some case management, but they should not be appointed as being a case manager. They may be the primary for some people with more complex health conditions, meaning they see them more consistently, but it's really with intention that they are the primary for that person. But really, it feels like, unlike other roles, the caseload themselves are all being touched by the nurses. Sometimes the nurses will divide it up and be like, this 50 are my primary, this 50% are your primary. But I feel like nursing should be available to everybody. It's just there's some people who get more nursing because of their needs and their person-centered plans.
I would subscribe to that. I think that I've also had the experience in doing fidelity reviews of working with programs that have overemphasized the generalist responsibilities such that you wouldn't recognize them as nurses.
Yep.
So, and having that specific nursing expertise and making sure that the nurse is really doing the full range of nursing duties, I think is really important. I think where this also gets tricky to tease out, right, is various ACT programs of various community mental health agencies have varying degrees of pharmacies, access to pharmacy, right? And so for those ACT programs that don't have access to pharmacy, nurses take an enormous role in packaging and managing medications, right? And so, and keeping all of that straight can take a large amount of time. And so the ability for those nurses to be able to dedicate the time to doing health promotion and some of the other tasks that I would say are really important becomes strained. So, you know, one of the things that I really do a lot of coaching with programs is, you know, the level of FTE and the staffing for nurses can be really critical, right? You don't want to shortchange any specialists, but particularly the nursing specialists. And if we're really trying to address the healthcare needs of people living with serious mental illness, we need to do a better job. People are still dying 20 years younger than the general population. And that's largely because their healthcare needs are not being adequately met. And so we need to really make sure that people are getting that preventive care, that they are following through with their healthcare appointments. And sometimes that can be really challenging, again, based on where people live and their access to healthcare and the degree to which individuals are getting adequate care. We still have communities where if you don't show up for an appointment, you're fired. You basically are disconnected from your health care, right? And so for people who have a real challenge for keeping track of time, not showing up for appointments can really have some serious deficits. So these are where nurses can really come in and provide a lot of coordination and care and make sure that things get followed up on. And I don't know about other states, but Oregon has really embraced coordinated care, the coordinated care model, right? CCBHCs have kind of taken hold in a lot of community mental health agencies. And that's really been a benefit because we have a lot of primary care physicians that are actually physically now located within behavioral health clinics. But that does really pose some interesting questions about how much of the ACT nurse's role should be about helping to also coordinate medical care now. And I think that there's maybe some good argument that that could expand, you know, the nurse's role in an effective way, but there's lots of dialogue that would need to happen in order to make that an effective approach.
Yeah, and it crosswalks with this question that Amber just put out there. How do we encourage nurses to engage more closely with clients with complex health needs? This is an area we struggle with in that there is a fear of working without orders.
Yes, this comes up a lot. I would agree with what both of you have just said about the nurse being more specialized because the medical management, especially with complex needs, is so great on the ACT team. I do think it's important for nurses to be familiar with and have knowledge of the generalist things so that they can help direct participants to other team members and maybe actually schedule them with the team members to make sure that those needs are met without having to actually, you know, use the nursing time to do it themselves. Of course, there's always going to be times that we do generalist things, and that's necessary and important as a team member on the ACT team. To answer Amber's question, how can they do more of the complex health needs? There are times when the providers can write specifically for ACT nurses to help them with their needs in the community. And there's that big question the whole team has to look at is the care gotten to be too much for the ACT team, and do they need additional resources or even to be placed temporarily into, you know, living nursing situation where it can be addressed? That is very individualized though for each team and for each participant, as we all know. I do believe though it's a valid concern for nurses to be aware of that we should always be working under somebody's license when it comes to orders and treatments and things though. We definitely talk about this quite a bit in the modules because it is a valid concern.
Yeah. Yeah, and so making sure that there's at least a standing order, right, that a nurse can follow under. And again, the extent to which a community mental health agency has a PCP, you know, working within that organization, and that they can quickly access that that doctor to get an order could also be a way to manage that.
So I see Katie had asked about any data that came out of the study, National ACT study about specific roles in turnover and retention, and how other states may be tracking that, or if they do. This is probably referring back to your 55% turnover when you looked at the years of 2018 to 21, I think was your years.
Yeah,
Did you get that data from your fidelity review data? Is that where you pulled it from?
correct. Yeah, and I would love to hear from other states if you know, Lauren, if you have any numbers off the top of your head about retention rates for nurses and the states that you work with. We did not collect retention rates from other states, but I would love to hear if that's comparable to what other states are experiencing, or if that's kind of unique to our state.
It's interesting because we extracted a lot of data out of the study that had fidelity data, is where we were pulling the information from, but we did not extract that data point, which is in the team survey for both, I think, the DACS and the Team Act. There's a table that will say what positions have been open in the past 12 months, and then you write out what positions were open, and that's a data point where you can grab to understand how representative was nursing as part of that turnover. What we did in the team leader survey, however, we were asking them, you know, of these roles, which ones are the hardest to hire and retain in of your typical ACT roles, and if I can show the rights. Showing just the table here. So the clinical social worker licensed therapist, this is about, I should have my N in here. It's about 300 respondents here, and it's across most all the US states. So clinical social worker, the licensed therapist was by far the hardest, and that's what we've been hearing. They have been, I think, the position on the team that has been most attracted to other types of work that paid higher and allowed for remote hybrid arrangements. Then also nursing was second. Co-occurring disorder specialists were third when it comes to the positions that were most challenging. It was interesting because Maria was surprised to see how low psychiatric care provider was. I wasn't. I think them and team leader tend to have the most staying power. They tend to get compensated a bit more fairly. They have a more loyalty, kind of allegiance to the team because they're part of leadership. So I wasn't surprised that they were on the low end. My estimate would be, you know, it'd be interesting to look at the difference between higher fidelity teams and lower fidelity teams, because I think that's one of the things that go into play is that higher fidelity teams tend to retain their staff, but retain their nursing staff. They feel like they are supported. They feel there's value in the work they're doing. So I'd be curious of how much that comes into play, because my instinct is our teams here in North Carolina have lower nurse turnover than 55% as an average, but I think I'm being influenced by higher fidelity teams and the nurses I've known to stay around. So it could be easily skewed. You all do fidelity reviews of the teams every year in Oregon?
Correct.
Yes. And it's with the DACS kind of version, OCEACT. It's more DACS, but a few substitutions. So it's more feasible. TMACT is a harder one to keep up with, an annual review. All right. I think I got most of the big ones here. Any other questions? It's 4:30. There was an evaluation link that was dropped in to the chat. Again, take time to Give us some feedback. Start giving us ideas of how you would love for this to live beyond SAMHSA funded support. And again, we really appreciate you, Heidi and Julie, for taking time, but also everything you put into creating all of this important resources.
Thank you, Lorna. Thank you, everyone. It's great to have your attention and get the feedback. Wonderful to see you.
Yeah, it's wonderful seeing you too. I'm losing all the screens here. There I am. All right, take care all. We'll linger here for a minute. Make sure you can get the link.